Hi there, I'm Dr. Paul Houle from Cape Cod Healthcare Neurosurgery. I'm going to give you a brief case presentation. So when we talk about doing disc surgery, or lumbar microdiscectomy, versus whether or not we want to do something transforaminally, I think the upper lumbar regions are very unique. If you look at the orientation of the facet joint, and you have to get to a paramedian or a medial foraminal disc herniation, how much facet are you going to take? This is a very straightforward, simple discectomy. But if you were to perform a microendoscopic surgery through a tubular retractor or an open procedure, think about how much facet you'd have to take. In fact, this is a fairly well described phenomenon and published in Neurosurgery in 2004, the unique characteristics of upper lumbar disc herniations. And in fact, the surgical outcomes for these cases are actually much worse than the lower lumbar ones. So I think this is a case where a transforaminal approach is particularly useful. So here we are with the needle placement. You see in the lateral projection, I've gone across the isthmus. I'm touching the disc space and completely avoiding the exiting nerve root. On the AP, which is slightly rotated, I'm definitely into the canal, and I know that my needle is going to be in the epidural space. Now, of course, you look at this and say, oh, you've done a lumbar puncture. I can tell you that the patient will respond if you puncture the dura, and I always take out the stylite to see if there's any evidence of CSF. You'll hear Dr. Ralph Wagner always preach that you really need to target your pathology. And if we remember the opening slide with where the disc herniation was located, it was right underneath the facet joint. If you look at my tubular retractor, I'm exactly targeting where the disc herniation is going to be. It's just medial to the facet joint and in the medial portion of the neuroforamen. So I know that when I put my endoscope in, the first thing I'm going to see is disc material. So as you'll see, that needle placement is the key to the procedure. And I can't stress how important a good fluoroscopy is. Your tendency is to be too far lateral. And I would argue that you almost couldn't be too medial. This is not an intradiscal procedure, this is an epidural procedure, and I put these images up here to demonstrate that this is not a good trajectory. This is an intradiscal approach. This is not where I would want to be. So here we are, and I'm going to let this video play and you can listen to it.
The endoscope is now into the spinal canal about the midline, and this actually is all the disc herniation right here because I know the dura is being protected at the 6 o'clock. Take that. I see some epidural fat at 2 o'clock and disc material at my 12 o'clock. Stop recording. This is the traversing nerve root traveling from 11 o'clock to 2 o'clock. You see it pulsating, and underneath you see the annulus and the disc herniation, most of which has been removed. The polar tip is underneath the traversing nerve root, and you can see there's nothing causing compression of the nerve root. You get a very good view of the traversing root all the way around. There's still some disc material here, which I think I'm going to continue to remove.
This is
There's
annulus.
Annulus, and the fluffy white stuff in between is disc material. The pulsating traversing nerve root, you see a little bit of annulus right there. You see some disc material that I've removed, and I don't really see any more that needs to be taken out. The dura is pulsating nicely.
So as you can see, you have really good visualization of the nerve root, and it's possible to remove the disc herniation. And I think this is a far better approach, especially for the upper lumbar regions. Thank you.